Okay, sorry about the pop-ups. We're going to start off talking about the endocrine system. We're going to start off with the pituitary gland, but it's important that you have a basic understanding of the normal functions of the endocrine system. So I'm going to do a brief review and then we'll go straight into the pituitary, but it is your job to fully understand the anatomy, physiology, and functions of the entire endocrine system. So just as to get us started, again, this is just a review, but the endocrine system itself uses chemical messengers in our body, known as hormones, as a means of regulating and integrating body functions. It helps us regulate digestion, use and store nutrients in our body. It aids in growth and development, electrolyte and water metabolism, and also we see some effects in the reproductive functions. Now, again, what you may see is that these chemical messengers may be transported by body fluids to other sites where they're used. And when that happens, when we have hormones that are secreted that aren't used immediately in that area, but they're sent to other organs to be utilized, those are you will talk about transport carriers. But you also have some hormones that will be released into the system and they'll be used in the immediate site or cause local effects, and that would be like an autocrine or a paracrine hormone. And I think your book talks about one of the hormones in the ovary as an autocrine or a paracrine hormone. Those like insulin is released from the pancreatic beta cells, and which inhibits the release. It's released from the same cells, so that would be an autocrine action. But when they act locally on the cells other than those that produce the hormone, the action is called a paracrine action, and that would be like the sex steroids of on the ovaries. That would be like a paracrine action. Again, there's major actions and sources of selected hormones in table 31-1 in your book. I would say you definitely should review that. It gives you the source, where the hormone comes from, what the hormone is, and the major action of the hormone. So some of those hormones we're actually going to talk about in detail and some we won't. The level of most hormones in the body is regulated by what we call a negative feedback mechanism. I think I had given an example of this when we talked about the air conditioning system, cuts on and cuts off based on how hot or cold the house is. Your endocrine system is very similar to that. The endocrine system will secrete certain hormones in response to them being low, and then you will suppress the secretion of those hormones when the body detects those levels as being high. The hormones are released into the bloodstream and circulate as either free or unbound molecules or as hormones attached to transport carriers. Your book talks about different types of hormones, and I want you to kind of have a basic understanding of that. Again, there's a table on 31-2 in your book. But some of what I want you to kind of focus on is steroid hormones, peptide hormones, amino acid hormones, and fatty acid derivatives. Peptide hormones and protein hormones are water soluble and usually circulate unbound in the blood. Whereas the steroid hormones and the thyroid hormones are carried by carrier proteins and are synthesized in the liver. The extent of carrier binding influences the rate at which hormones leave the blood and enter the cells. The half-life of a hormone, which is the amount of time it takes for the body to reduce the concentration to half, is positively correlated with the percentage of protein binding. So an example is thyroxine, which we're going to talk about as a thyroid hormone. It's 99% protein bound, and so its half-life is 6 days. On the other hand, aldosterone, another hormone that we're going to refer to, it's only 15% bound, and so it has a half-life of only 25 minutes. As you can see on the slide, the steroid hormones which are like aldosterone, the glucocorticoids, your estrogens, your testosterones, these actually act inside once they're inside the cell. These are generally bound to protein carriers for transport, and they're inactive while they're bound, in their bound state. They become active depends on the availability of transport carriers. Unbound adrenal and gonadal hormones are conjugated in the liver, rendering them inactive, and then they are excreted in the bile or urine. The thyroid hormones are carried by transport carriers as well and are rendered inactive by the removal of amino acids in the tissues, and then the hormone is conjugated in the liver and eliminated in the bile as well. So you need to understand when they're what it means to be free or bound to proteins, which ones require to have protein carriers, and which ones can just be free in the systems. Peptide hormones or your protein hormones, these are things like your growth hormone and your luteinizing hormone and your thyroid stimulating hormone, follicle stimulating hormone, adrenocorticotropic hormone, insulin, glucagon, parathyroid, some other ones in the chart you can look at. These have a very short half-life in the circulation. So most of these are water soluble and they circulate freely, and they actually degrade once they're inside the cell. So the steroid then you have your amine and amino acid protein. That's like your dopamine, epinephrine, norepinephrine, thyroid hormone, etc. So just to give you a basic review of those, again, you can find more information about those in your charts that I gave you reference to. And this is, again, just a review to hit some terminology. This is stuff that you should have had in biology and physiology. So we've touched just a little bit about what hormones are and how they're transported in the system. So we're going to move on to chapter 30. Move on in chapter 32. Apologize for the typo. And that should say chapter 32. And this is going to be disorders of endocrine function. So one of the first things you have to understand is we're going to talk about hypo and hyperfunction of the gland. So when we look at hypofunction of an endocrine gland can occur because of many things. You might have congenital defects, impaired blood flow. With the congenital defects, that it could lead to the absence or the impairment of the developed gland. The gland may be destroyed due to impaired blood flow or infection, inflammation, autoimmune or neoplastic growths, and increased aging or drug therapy also can inhibit the receptor sites absent or defective. When we look at hyperfunction of the endocrine glands, that's associated with excess hormone production. So either hyperplasia of the gland or a hypersecretion from a hormone-producing tumor. Hyperfunction symptoms, they can be what we call paraneoplastic, meaning they're caused by hormones that are secreted by tumors that are not in the endocrine origin, okay, or not endocrine tissue. So primary, secondary, and tertiary. Your primary, when we look at primary hormone or primary endocrine disorders, this abnormality is actually going to take place in the target gland we're talking about. So this target gland is responsible for actually producing the hormone. And so an example that we might use would be like a thyroidectomy, when you have surgery to remove the thyroid gland. Removing that gland may produce a primary deficiency of thyroid hormones. Okay? So secondary deficiency or secondary disorder the target gland is normal, but its function is altered because there's defective levels of the stimulating hormones or the releasing factors from the pituitary. So in the same situation, looking at the thyroid, in this case, if we had a problem with the pituitary gland, or if there was a removal of that gland, like a hypophysectomy, the removal of the pituitary gland actually eliminates the thyroid stimulating hormone release. And because that stimulating hormone is not released, the thyroid itself, even though there's nothing wrong with the thyroid gland, does not release the thyroid hormone because it's not been told to. And so that would bring about a secondary deficiency. A tertiary problem would be like an abnormality in stimulation from the hypothalamus. So both your pituitary gland is intact and the target organ, but how they're both understimulated because there's a problem in the hypothalamus. Typically, we see problems with the hypothalamus in patients that have had like a cranial radiation therapy and like cranial pharyngioma and things like that. So that something wrong with the hypothalamus would cause a hyposecretion to the pituitary and the target organ, and so even though those two organs are fine, the hormone that we need is not being released. So that just gives you a little bit of, I think your objectives say you need to know some examples. So again, primary would be actually removing or damaging the actual gland that is secreting the hormone. So a thyroid gland would be removed, or thyroid gland would be damaged, causing a variation in the secretion of thyroid hormone. Whereas, an example again, if there was a problem with the pituitary gland, if there was such a removal of the gland for a reason of cancer or so what, then that gland would not be able to put out the appropriate amount of stimulating hormone to the thyroid, allowing the thyroid to understand that it needs to put out the thyroid hormone. So there's a problem in the negative feedback system. So as we move on to the pituitary gland itself, you have the anterior and the posterior. In the anterior pituitary gland, you have the thyroid stimulating hormone, you have the adrenocorticotropic hormones, the follicle stimulating hormones, the luteinizing hormones, growth hormone, and prolactin. Whereas in the posterior, you're only dealing with two hormones, your antidiuretic hormone and your oxytocin. Now, we've already covered the renal section where we talk about antidiuretic hormone and the diseases that are associated with that, such as diabetes insipidus and SIADH. Again, remembering when we had too much secretion of the antidiuretic hormone or too little secretion of the antidiuretic hormone. So I want you to understand that in the anterior pituitary gland, all of those hormones, except for the growth hormone, exert their primary effects by controlling the biosynthesis and secretion of hormones from other target glands. So an example of what that means. The ACTH, or the adrenocorticotropic hormone, controls the release of another hormone called cortisol. That cortisol is released from the adrenal gland itself, and so that's what we see here. So you have the pituitary gland secretes ACTH, so adrenocorticotropic hormone, and that hormone, once circulating in the system, triggers the adrenal gland to release cortisol. Okay, thyroid stimulating hormone, again, is secreted from the pituitary gland, and once it's in the system, the thyroid gland itself recognizes that thyroid stimulating hormone and goes ahead and produces what we need for our body is thyroid hormone. And again, from the thyroid gland. Luteinizing hormone and follicle stimulating hormone, these control sex hormone production and fertility. So the only one is growth hormone that does not directly affect another secretion, if you will, from another organ. The next picture is just a slide that kind of gives you an idea. If you look at this side right here, this would be the anterior pituitary and the posterior pituitary. It's a lot smaller. The anterior pituitary, again, you can look at this chart and see that it puts out growth hormone. The growth hormone in the end works on the bones and the soft tissues. ACH is produced and secreted, which works on the adrenal gland to secrete adrenocorticosteroids and so forth. And then what you do is you look at this is a negative feedback system. So the pituitary gland senses the need, or senses low levels in the blood, and senses the need to secrete these hormones. So it secretes, let's just use an example, the adrenocorticotropic hormone. And once that is secreting in the blood, the adrenal gland picks it up, and because it's picking it up, it thinks that it needs to secrete the adrenocorticosteroids. So those are secreted, they circulate through the system, And then you have a negative feedback. So then it would come back over here and it would tell this gland, hey, we have enough adrenocorticosteroids, go ahead and quit production. The problem is that when this feedback system is messed up, and what we see is the adrenal gland keeps pouring out the adrenocorticosteroids, and the feedback loop never gets back to the pituitary gland. So the pituitary gland still thinks that it's low and keeps putting out the ACTH, and then you have a bad cycle. It could be the opposite, where there's not a communication between the glands themselves, okay? And so the body is not using the appropriate hormones like they should, and so but there's a failure of it to shut off. So that's one way that you could look at this as a negative feedback system. Your air conditioner in your home is supposed to cut on when the air gets higher than what it's set at, and then it cools the air off, and then it shuts off when it gets cool enough. If that did not communicate to each other, either the air conditioner would run all day long and overcool, or it would never come on and your house would be very hot. And that is exactly what's happening in these disorders. So, let's move on to pituitary adenomas. The most common cause of hyperfunction is a pituitary adenoma. Other causes may be hyperplasia, carcinoma of the anterior pituitary. You might have secretions of hormones by extrapituitary tumors or hypothalamic lesions. So other cancers in the body can possibly cause the hyperfunction. So the most common cause of hyperfunction is a pituitary adenoma. Okay. Manifestations of pituitary adenomas relate directly to the hormone that is involved. And the book uses the example of the lactotrophic adenoma. So what it tells us, lactotrophic adenomas are usually small benign tumors that are composed of prolactin secreting cells. Okay, this is the most frequent type of hyperfunctioning pituitary adenoma and accounts for about 30% of all diagnosed cases. But what happens is these prolactin secreting cells cause a hyperprolactinemia, which is elevated levels in the blood, and that inhibits the secretion of the luteinizing hormone. Luteinizing hormone is necessary for ovulation in women, and so what we see is no ovulation, which is amenorrhea. So they're not having a cycle and not ovulating. So they're not menstruating. Also, galactorrhea, which is produced when the luteinizing hormone is not available. And so that is just spontaneous milk secretion from the woman's breast. We also will see infertility. In our males, erectile dysfunction and a low libido, these are very common if they have hyperpituitary function here. In general, they may cause vision abnormalities and increased intracranial pressure. Again, remembering where the pituitary gland is involved is very important. You know, it's like a little pea-sized structure, and kind of like sitting inside right in the middle of your head, right? You know, and the optic nerve is pretty close to it, and so you can have visual field of abnormalities and so forth. And it's kind of like a tumor, so as it grows and it puts pressure in the brain or on those areas, you start to see those other problems, and so in the signs of intracranial pressure being increased. We focus mostly on the growth hormone and the insulin growth-like factors. So you kind of have to understand what growth hormone is and why it is, or how it relates to the insulin growth factor. So growth hormone is also known as somatotropin. It's an amino acid polypeptide hormone that is synthesized or made and secreted by the cells called somatotropes. It is extremely necessary for growth and regulation of metabolic functions. Many of the effects of growth hormone are mediated, or mediation means that they're helped, mediated by insulin-like growth factors, which is your IGFs, and these are produced in the liver. Now, growth hormone cannot directly produce bone growth, okay? So what happens is the growth hormone is secreted and it acts indirectly, causing the liver to produce insulin growth-like factor. And this specific one we look at is IGF-1. It appears to be the most important growth factor in terms of growth, and is the only one measured in lab tests. So insulin-like growth factors act on the cartilage and the bones to promote growth. So growth hormone secretion is stimulated when your blood sugar is low, so hypoglycemia, or maybe in times when you've been fasting and your body is in starvation mode, or you have increased amino acids in the blood, stress levels are very high. So these things happen and stimulates the secretion of growth hormone. When growth hormone is secreted, it circulates and the liver responds by secreting insulin growth-like factor. And together, because the insulin growth-like factor works on the cartilage and the bone, you start to see an increase in the growth. Now, what inhibits growth hormone secretion would be, let's see. So what is inhibit? I'm sorry, I apologize. Brain malfunction there. Growth hormone secretion is inhibited when blood glucose levels are high. So if the patient is hyperglycemic, or if they have free fatty acid release, if there's detection of cortisol in the blood, and sometimes, or a lot of times, in obesity. So that obesity would inhibit the growth hormone secretion. So, what would happen if we had too much growth hormone occurring before puberty or before our epiphysis of the long bones fuse? We would get taller and taller and taller until obviously we either stop growing or we would be what we call gigantism. Now, in adults, where our epiphysis of our long bones have already fused and we can't get any taller, if we had excess growth hormone as an adult, our soft tissues and our very small bones would actually continue to grow wider, and that is known as acromegaly. Acro meaning large, okay? So acromegaly. In the child, other endocrine causes of tall stature could be sexual precocity because of the early onset of estrogen and androgen secretion and excessive growth hormone. So growth hormone secretion is not, or hypersecretion is not the only reason that a kid can be tall, obviously. Parenting and familial things occur as well. But sexual precocity is also a cause of a child growing too tall. So let's specifically talk about growth hormone itself and adults. In adults, when we have too much growth hormone, again, I told you it works on the liver. So we have too much growth hormone in the body secretion. So it's floating around, and the liver senses that, and so that it senses the liver to secrete the insulin growth-like factor 1, IGF-1. And because that insulin growth-like factor is circulating, it causes the manifestations of acromegaly. Acromegaly is fairly rare, about 3 to 4 cases of every million people. However, if you look at the Guinness Book of World Records or sometimes watch TLC, they'll have many, many programs about people that do live with this disease. The most common the most common cause is, again, a somatotropic adenoma. The onset for this disease is often insidious, and the pituitary adenoma secretes growth hormone. Even though there's increases in the IGF-1 levels, it still leads to an overgrowth of bone and soft tissue and hyperglycemia. So there's a problem with the negative feedback. Okay, so the pituitary adenoma continues to secrete growth hormone, even though we have appropriate or elevated levels of our IGF-1, which is supposed to tell the liver to tell the pituitary to stop. But this is an adenoma secreting the hormone, not necessarily the pituitary gland. So this is just a couple of the manifestations of acromegaly. So when you look at it, you can kind of see in these pictures, obviously the picture in the middle, it would be a picture of somebody that had excess growth hormone when they were young because they're very, very tall, and that would be like gigantism, as opposed to the pictures on the far right and far left. Because an adult cannot grow taller, they must widen. And so some of the examples that I'm going to give you are kind of the pathology behind why these things occur. The soft tissues the bones can't grow in adults because the hypophysis is already closed, but the soft tissues can. So the small bones in the hands and the feet, they will expand, causing the hands and the feet to grow larger, as in the picture you can see. The membranous bones in the face, they also grow and widen, and it causes the patient to have a slanted forehead, as you see here. They'll have a very broad and widened nose, and they have what we call a protruding jaw. So they'll have this underbite, and pretty severe. And that protruding jaw makes chewing very difficult because their teeth also spread pretty they spread a lot. The voice will deepen due to the changes in the larynx and the respiratory tract. And all those soft tissues getting larger and larger, it causes the voice to become very low and deep. There's also vertebral changes that cause the patient to become hunchback, or what we call it kyphosis. There's an impaired glucose tolerance. This is very common, secondary to insulin resistance. So what we see is hyperglycemia in this patient. Hypertension is also seen. You'll see on your slide with all the manifestations, they have enlarged heart, enlarged spleen, enlarged liver. In this case, bigger is not better. The heart muscle becomes very big, but it's not very effective. The spleen is very big, and that's not a good thing. The liver also enlarges. The skeletal muscles enlarge, but they're very weak. Okay, so you have lots of organs involved here that become larger, but they're often not working properly. You might see sleep apnea is very common due to the pharyngeal changes that these patients occur, and paresthesias due to nerve entrapment. It's kind of like there's just nowhere else for these things to go. You'll see things like excessive sweating and unpleasant odor. They'll be very oily skin. They're intolerant to heat. These are just some of the other manifestations that you will see with acromegaly. So, when we say why do we have hyperglycemia in the patient, this is kind of the reasoning. There's a decreased glucose uptake by the tissues. The tissues aren't uptaking the glucose, and the liver doesn't understand that. There's no communication, so there's an increased glucose production by the liver. So that gluconeogenesis is occurring even though we have enough circulating glucose. The tissues in the body are not taking them up. And so because the tissues aren't responding, the liver thinks it needs to keep putting it out. So you have decreased uptake by the tissues with an increased production by the liver. And then you have increased insulin secretion trying to keep up and meet the needs. What happens is these three lead to what we call glucose intolerance. There's the beta cells in the pancreas are stimulated to produce additional insulin, and over time it causes them to burn out and they just quit working. And so what we see is insulin is eventually won't be secreted, and we won't be able to manage the blood sugar, and they'll end up with diabetes mellitus. So overall, you have a decreased uptake, an increased production, and increased insulin secretion. It's just that none of them are really communicating. So diagnosing acromegaly, typically you look at a history and physical exam. They will draw growth hormone levels. They'll do what we call an oral glucose challenge test, and we see elevated growth hormone levels that in our bodies normally, if we did this oral glucose challenge, we would actually see a suppression of the growth hormone. That's not the case here. The growth hormone still showing elevated levels even after this oral challenge. Okay, So the body is still producing growth hormone even though it's not needed. The other thing that we see is elevated IGF-1 levels. Okay, so we have these insulin growth-like factors. This level is extremely high in the patient, and so that would help diagnose it. And of course, they can do a CAT scan and MRI to further look at the gland itself. So let's move on and talk a little bit about the underfunction or hyposecretion of the pituitary gland. Specifically, we'll talk about the growth hormone as well. So again, decreased secretion of the anterior pituitary hormones. You have to understand that 70 to 90% of the anterior pituitary is destroyed before we ever see symptoms. If, in fact, all of the anterior pituitary hormone secretion is low, then we call it panhypopituitarism. Panhypopituitarism. Again, all the hormone levels are low. We might only have just one level that's low, like growth hormone's low. Okay, and you might see the signs of that, or you might see the follicle-stimulating hormone is low. But what you don't see usually is all of them low together. And when that does occur, that's called panhypopituitarism. Okay, so low secretion of all those anterior pituitary hormones. So some causes of that could be radiation, tumors, impaired blood flow causing an infarction, could be hypothalamic problems. Again, I think some of the other hypofunction causes I gave you was, again, impaired blood flow, infection, inflammation, autoimmune, neoplastic growths, and so forth. Manifestations. The patient is usually chronically unfit. They have a lot of weakness and fatigue, loss of appetite, probably some impaired sexual function. They're intolerant to cold. Their body doesn't respond really well. And so with hypofunction, again, what we see is gradual loss of these anterior hormones. And so I've kind of put it in perspective for you. There's what we call a, I'm trying to think of the word, like a pattern of loss, if you will, anticipated pattern. Typically, we'll see the first hormone that's gradually lost would be the growth hormone. It'll be the first one undersecreted, and then you'll have luteinizing hormone and follicle-stimulating hormone. So growth hormone deficiency first would be like short stature. They'd have delayed growth and delayed puberty if they were children. It's usually asymptomatic in adults. We don't really see anything with that. But then it'll progress, and you'll see a decreased luteinizing hormone and follicle-stimulating hormone levels, and that would result in like hypogonadism, cessation of menses in the females, and impotency in males. Then you might see a decreased thyroid stimulating level, which would cause hypothyroidism, and then we'll see decreased adrenocorticotropic hormone levels. And again, typically these are the last to become deficient. There's a controversy over that in prolactin, but typically we see the adrenocorticotropic hormone being last. But what is the most serious deficiency? The most serious deficiency in hypofunction of the pituitary gland would be ACTH deficiency. It's the most serious because it causes adrenal insufficiency, and we are going to cover that in detail. But adrenal glands are the glands that regulate our sugar, salt, and sex hormones, and so they have a huge role in our our fluid volume and our electrolytes, things like that, our mineralocorticoids, glucocorticoids, the sugars, our salts in our body, and so forth. And so those, when we don't have enough adrenal gland production, that can be fatal. So, real quick, hypopituitarism, growth hormone deficiency is what we're going to focus on, but these are some other causes of short stature in children. But growth hormone, if of course they did not have enough in a child, it would lead to what we call or consider dwarfism or short stature. You may also see things like protein calorie malabsorption and chronic kidney disease and poorly controlled diabetes, malabsorption syndromes. All of these things can cause short stature in children. So our manifestations of growth hormone deficiency, again, these kids will have normal intelligence. There's nothing wrong with that. They're just show short stature, and they'll have usually obesity with immature facial features. Oh, and I just realized I spelled that wrong. I apologize. And then skeletal maturation delays as well. In our females, again, you'll see infertility and amenorrhea. The males, an extra small penis can lead to impotence as well. Puberty is often delayed. And the very last slide that we'll talk about here is a term called precocious puberty. You need to understand this one in detail of the numbers. So what is precocious puberty? It is defined as an early activation of the hypothalamic pituitary gonadal axis, resulting in development of secondary sexual characteristics and fertility. So it's early onset, basically, puberty. So what we see is it's defined as the appearance of secondary sexual development, so like the breast buds and the menstruation, things like that. So those things will be, if they develop in a child before the age of 7 in a white girl, or before the age of 6 in an African American girl, it would be considered precocious puberty. And the age for boys, regardless of race, would be 9 years of age. So if we see the boys having the enlarged sexual genital enlargement is one of the most common signs in boys, and if that happens before the age of 9, then they consider it precocious puberty. One of the things that can cause that is a tumor of the central nervous system. There's other things I'm sure that can cause that. It may be idiopathic. It may be caused by a gonadal or adrenal or hypothalamic disorder, but often it can be a benign and malignant tumor that can also cause it. And that's usually more seen in the boys, the tumors. So the diagnosis is made in girls based on the physical findings of early breast development, and again I said they're menarche. And with boys, they have again the enlargement in the genital area. So that concludes actually the initial portion of the endocrine system, part 1. I will come back and we will have thyroid disorders as part 2.